Welcome. We're talking about Transoral Incisionless Fundoplication today. And we have Dr. Matt Skinner from Scripps Clinic. We have Dr. Katie Blevins. So Dr. Skinner, it looks like you have the device in and getting ready to create a fundoplication. What are you looking at? When would you do this kind of case? What kind of patient would you do this on?
So we are looking at patients who need some sort of augmentation of their anatomy for reflux disease. And so most of these patients have had either severe esophagitis or pH testing confirming reflux. And then I'm looking for really a minimal defect here at the hiatus. So we're looking at something with a hiatal hernia that's less than 2 centimeters. I'm also looking for we're assessing the Hill grade, and so these are all either going to be Hill grade 1, Hill grade 2 patients that we're performing this procedure on.
As you're starting this procedure, we'll go over a little bit on the technique. So this looks like something Dr. Blevins often give us. Can you tell us what it is that you do? What's your magic on the hernia repair?
So as we already discussed, the C-TIF device is really great for patients who don't have a hiatal hernia, and where someone like me comes in is when people have a bigger hiatal hernia, so more than 2 centimeters or a Hill grade 3-4 valve. And in those situations, we do something called a C-TIF or concomitant TIF, where first someone like me, a surgeon, will go in and fix the hiatal hernia, and then with partnerships or some surgeons themselves will go in and then make the anti-reflux procedure or do a TIF.
So this looks like after a good repair, good esophageal length, you're at the 11 o'clock position. Can you walk us through the steps?
Yeah, I mean, so we're at the 11 o'clock position. You actually load 2 fasteners every time you're making application here. This is the device. You pull this all the way back, click these 2 buttons here to load, and then you advance the catheters back down to the tip. So what I'm going to do first is move towards this 11 o'clock position. I have a helix corkscrew, and what I'm trying to do is get this approximated into the Z line here. So we're corkscrewed in, and then I'm going to open up the device, which kind of frees this helix, and we do something called burying the blue. So we're pulling the TIF device back until that blue little knob is buried there below into the esophagus. And then I'm going to retract here. I'm going to move my helix to the lock position so it doesn't fall forward. So I'm going to continue to retract, continue to close my device. I'm trying to shift more posteriorly, more towards that 12 o'clock position. And we'll close all the way. And once this is closed, it kind of strips, so it'll go silent from the click that you heard. And then I'm going to push in on this button here. We're going to push off of the diaphragm about 1 centimeter into the patient, and then we're going to fire our first shot. I'm going to unlock my corkscrew and move away here. And what you can see, if we can adjust the endoscope here, you actually have 2 H fasteners here. And these H fasteners are connecting the stomach to the esophagus and plicating those 2 structures together. That's going to scar down here over the next month or so. The
device, it looks big. Do you have to dilate prior to placement of the device?
I always use a 60 French Savory dilator prior to placement of the device. The device is, again, the scope goes within the device itself, so the scope is going through the device. So as you advance the endoscope down, you're also going to advance the device down.
After the valve is created, what do you see surgically?
So
robotically, laparoscopically. What does it look like? Does it look like a partial valve? Does it look like a...
Yeah, so it looks actually, it looks like an inline valve, and I know this because we've had patients that have recurred, not us personally, but when we've had patients, I've seen patients that have had a recurrence. It's usually just the paraesophageal hernia that has recurred. When I get things back down, the wrap looks perfect. The valve that was done for this looks fine. So it's kind of an inline, flap valve that's done, and it's a hardy valve. It's just fine.
Yeah.
It's sturdy. Have you had to re-TIF a patient, Dr. Skinner?
I think I've probably re-TIFed one out of about the past 200 that I've done.
So very
And so it's a really durable fundoplication.
Yeah, even in the patients that we have to repair the hernia, when we fix the hernia, the valve comes down, the valve looks very similar to what we created. So how many fastener sets would you place?
So I'm going to place 3 sets into this 11 o'clock position. And then after I do that, I'm going to shift over here into my 1 o'clock position.
What kind of length would you like to achieve on this kind of valve?
I am trying to achieve at least 3 centimeters in length. And whenever you're able to suction and decompress the stomach, you're really able to do, I pretty consistently have about a 4 centimeter valve on these patients.
That's nice.
Yeah. So we're around on the 1 o'clock side here at this point.
I think the beauty is every valve looks very similar and it's very reproducible. And the common question that I have from our audience, our GI physician, is does the beauty of the valve relate to its functionality? Meaning, does it have to be exactly perfect 3 centimeters and 270-degree wrap? And does that correlate with how it functions, do you think?
In my experience, it's you're able to get a very, very reproducible 270 plus valve, 3 to 4 centimeter valve, almost greater than 95% of the time.
So you're telling me you're perfect all the time?
No, but I'm telling you that the device itself allows you to create a very, very reproducible valve.
Yes.
So sometimes you can't get the length that you want, and sometimes you have to make minor adjustments, and sometimes the model is made out of plastic and the corkscrew strips out. But the pH data that we have on our patients post-procedure certainly approximates that of a Nissen fundoplication. Because we don't have because we're wrapping bidirectionally, you're not really introducing any torque into the system. We have a very low side effect profile valve that we come up with pretty consistently.
So it's effective, it's feasible, it's good to do even with a larger hernia. Your safety profile is very good, would you say?
Absolutely.
Yes. Okay. And would you do this in a patient with esophagitis, with Barrett's esophagus? Are there contraindications to endoscopic fundo?
I'm probably not going to do this in somebody with active LA grade C esophagitis, or if they have any stricture that would preclude the device from going down. Barrett's esophagus, I don't have any hesitation to doing this. It doesn't really interfere with the esophageal visualization on future exams, so I think you're able to monitor that very, very closely moving forward.
Very nice. That's a wonderful summary. Thank you so much.